Appreciate it. Thanks for coming. That filled up right at the end. I thought it was just me and him right there. Yeah. Appreciate it. So my name is Ben Lewis. We're going to talk about beds today, chaos to clarity, building a bed program in your facility. Before we get started, can you pull your phone out, calculator real quick? I just want to, this is something I like to do with all my classes, just to see what kind of experience is in the class, because what I like to do if we have time is to have you guys talk to the group and to each other. This is small enough we don't have to break up in groups, and share your experience too, because there's going to be more experience. So go ahead and we'll do it really quickly to get your number of years in healthcare. It doesn't necessarily have to be as a biomed, but how do you connect to what we're talking about? And we just want to kind of figure out where we're starting, because no matter who you are, once you hear that number, you probably feel like you can get something out of the class before we leave. So I'm going to start out with 28, my number of years in healthcare, and Jason's going to give us a number at the end. So Jason, you want to go ahead and go? Healthcare. 20, 30. She gave me a dirty look. No, I'm just kidding. Yeah. 18, 10. She gave me a dirty look too. 30, 3. 1, and this is good too. So this is your opportunity. You're around 30-year veterans in healthcare too. 20, 12. 172 years of experience. That's a good start for the class. Even though this is a small class, there's a lot of days sunset seen in here, and we'll be able to come up with something more than I know. So feel free to share your stories or share your concerns or thoughts. Why does bed management matter? Well, the reality is beds are critical to everything in a hospital. There's a word that I'm going to say that you probably hear. I know some of you have heard, and it's called throughput, right? Just by sharing that word with your administration, they're going to have a little bit more trust in you, that you understand how a patient gets into the building, seen and out of the building, and beds are a critical component to that. So common pain points are that they're managed. Anybody in a system here? One. Anybody else in a system? What system are you in? How many hospitals is that? 10, right? So sometimes it's not unusual. I didn't really do an introduction. Sorry. I'm CEO of TechniHealth Solutions. I do have those 28 years in healthcare. Most of it is biomed background, also facilities and supply chain, and healthcare administration. So this is where the healthcare administration, supply chain, and biomed piece is where you're going to kind of see a lot of the experience that we talk about, and my viewpoint. So if you're bringing a nursing viewpoint, I'd love to hear. We've got a former nurse here, I think, and talk about that as well. So managed inconsistently across locations may be because of a merger, or because just no one has said, I'll take that, right? Facilities might have it here, supply chain, etc. Those are common pain points. And then just untracked across life cycle stages. So if you do not have a managed bed program, when are you buying your beds, right? How often do you replace them? Are you gonna do an moment and have to cut a $20 million check, right, to make things right? Or are you managing that out? These are common pain points of bed management. So fragmentation of oversight leads to increased cost, more downtime, and really coming back to that word is reduced patient throughput, or challenges with patient throughput. I heard Jason's here, and I've heard him say before, if you're really doing your job well, I don't know, there's a balance to it too, but if you're really doing your job well, they kind of forget about you in biomed, right? If your throughput is impacted in any way, again, that word thing, that's a way for you to connect to your administration. It's a big deal, right? And they are gonna think about you, and not in a good way. So, all right. So today's common problems, no clear ownership. We're gonna talk about that here in a moment. That is the most common problem that I see in bed management, is no clear ownership. Unknown asset data, and maybe it's they usually know the models that they have, right? And maybe they know the numbers that they have, but they don't really, I see often they don't know the age of their units, right? When are we going to start replacing them? When should we replace them? These are common problems. Inconsistent maintenance, that's going to vary vary satisfaction with your bed program by site if you have inconsistent maintenance deployment. Fragmented service, different types of parts, different availability. Do you have beds downstairs waiting to be repaired for your bed repairman to land next Thursday? These are issues that we see. And then poor vendor leverage. If you do not have oversight of these numbers, you cannot use that as leverage with your suppliers, right? How much do I spend with this person? With this OEM? What am I asking them to do? What am I asking them to change? So that's a common problem. If you don't have oversight and leverage, and if you don't have oversight, you can't provide leverage, and then you really can't provide stewardship to your organization. So I'm not providing specific. I've implemented multiple bed programs and advised on multiple bed programs, and I won't provide specific places for this case study, but this is an example of really them all in amalgamation. So what I've found is standardization, fewer bed models, harmonizes your parts, harmonizes your training. If you're not part of the decision, or if you don't make the decision for your bed purchasing, becoming part of it through bed management, which we're going to talk more about, is going to allow you to have a voice in standardization, which is going to create predictability. If you have a dozen models of beds, replacement plans can become more challenging. Feedback after replacement, right? Now I'm taking feedback on a dozen models instead of 2, and it becomes difficult for you to make those decisions. Safety, obviously you have more failure points, reduced efficiency, and financial stewardship. Again, we're kind of circling around all of the same space, but financial stewardship, if you have more SKUs, you have more cost to manage them, you have less oversight, so it just becomes a challenge. So bed management touches every function. Most of us are in the HTM field that are here today or support the HTM field. I've talked to people at this conference who where beds report to or are completed by facilities management. Anybody have facilities to do their beds in here? Anybody? No? Biomed, everyone? Okay, good. It touches nursing in many ways. Satisfaction. I don't know if y'all noticed, in my experience also, nursing week, they serve crab. HTM week, they don't serve crab, right? You know what I'm saying? So nursing, it's really important for us to connect with nursing on how it impacts them. They use it daily. It impacts safety. It impacts their livelihood, their license. They have to trust the scale on that bed to administer medication, right? So they're definitely one of our stakeholders. You will not be eating crab if you don't get on, on HTM week ever, if you don't get on board with the nursing and not just beds, but with your biomed program. EVS is a major component in bed health, right? We're going to talk about something called a RACI, but any hospitals have EVS clean their beds daily or through. Okay. Does anyone have EVS inspect your mattresses? Turn. Right. Is there a protocol for it, or is a policy for it? Yeah, they just let you know. Right on. Okay. My concern this is why I do recommend EVS does this. Biomed's not going to have enough touch points, on that mattress. I like to lead by assuming my family member's the patient, right? And if I looked at this and I said, okay, who do I want responsible for making sure this happens? Cleaning the beds, you're wiping a rag over with a disinfectant, notifying at that point that there's a penetration and an infection prevention issue, I think is a great step to consider. Procurement strategy is supply chain. So what beds will I be working on? I was in a leadership summit earlier this week, and one of the comments was about a specific OEM. bed model, right? And they wanted to talk about that. So not only, you know, the nurses, they should have a heavy weight in bed selection because they're so close to the patient, right? So you do want them involved in that. But obviously there's a weight in your selection process that you want HTM to be involved with too. So partner with your supply chain on that. So you might want to speak to that on weighting, kind of how you do that for asset selection in your facilities. Anybody have something that they do?
We standardize and then as, so for example, there's a bariatric facility going in next to one of our hospitals. So now we're going to select what is our standard bariatric bed as opposed to the med surg bed and ICU bed. So it's categorize it.
Who do you work with to select, and how is that selection weighted? You're doing an RFP. So does Biomed have a percentage of weight in that selection, or are you just on a committee, or how does that work?
Yeah. So it's a report card at the end, and all those are equal. So Biomed, we're going to vote. Supply chain, we're going to vote. Clinical, nursing, we're going to vote, and they're all weighted.
Okay. If you do not have, thank you. If you do not have that type of influence in your organization, you know, someone said, be the change you want to see in the world, right? And that's really, this is, sometimes there's not a direct path to someone's door that's just going to open this up to you. It may take an S-bar, right? Here's the situation, background, assessment, and recommendation to a leader. To me, that's one of an S-bar and a RACI, which I'm going to show you here in a minute, is one of the best leadership tools to connect with administration or someone that's going to make a decision to include you. They have to see value in your opinion, and you may have to produce it before they accept it, right? I've been part of that. So a system-wide strategy means aligned definitions, clear roles, and shared accountability. But it really is a team. Here's where I talk about a RACI. You can see. Let me see if here we go. Responsible, accountable, consulted, and informed. So responsible is a person or people who actually do the work, right? Accountable is the person who ultimately answers to the task. Biomed director, you know. Consulted are the people you have to talk to before they make the decision. And informed are the people who need to be informed about that decision. So who owns the fleet, right? There has to be some accountability. Who owns the standards? Who defines the specs, the models, the maintenance? And so you can get really granular doing a RACI document, but it can be where you fall back on that RACI for years to come, right? Until there's a change, and it's a living document. You may move responsible, accountable, consulted, and informed around a little bit. So again, who owns life cycle planning? Who owns capital requests, right? Somebody has to trigger. Oh, this is one of my favorite. I don't know who said it. Maybe it was Joe Rogan. I don't know. I mean, someone said, you know, we live in a 3D world. It's only action matters. Thought doesn't matter. Intent doesn't matter. You have to take action for it to, for it to matter. So who's going to order those pumps or order those beds? I've seen it before. Beds fall through the cracks, right? And again, you end up with a XX million check that you have to write to get correct again, So this is what one might look like filled out. I'll let you digest that for a second. This is just an example, but my advice would be to work with a team to be able to define these. For example, clinical engineering, bed performance monitoring. You may be responsible. I don't think, again, this is just a sample. Let's see, bed connectivity, right? IT is going to play a part in that. So it's going to be as detailed as you need to make it, but having a RACI for bed maintenance, and really, I think this is maybe one of the top 3 or 4 tools that I use as a leader, is this RACI platform, right? Yeah.
So also what is important is the peripherals on the beds too. So when you're guaranteed connectivity, all whatever, and then
Low air loss pumps,
yes,
mattresses,
Yeah.
bed extenders,
bedboard,
bedboard,
like,
bedboard connectivity,
Yeah.
right? Yep. So exactly. There's going to be, you'll be able to get really deep into this, and it'll start off smaller and grow as problems happen. We need to add that to the RACI, right? So if you don't have, and we do run across hospitals that do not have medical equipment committees, medical equipment subcommittees. If you don't have that, this is a great place to start as a bed equipment work group or a bed governance subcommittee or a bed governance work group. That's a great place to solve a problem, because this is an industry. We do find it as an industry opportunity, and perform multidisciplinary collaboration, right? Supply chain, finance, etc. So your core committee members you're going to want to have an executive sponsor. For beds, it's probably going to be a COO. Well, it could be any one of them, actually. A COO, a CNO, or a CFO, actually, right? The beds kind of can fall anywhere. Anybody have any thoughts on that? Your HTM leadership, facilities, nursing, supply chain, and finance. Finance may be an ad hoc partner, but it depends on how your capital season goes, right? If you're releasing capital quarterly, you may need them at each meeting. Is anybody missing that you'd want? There's probably IT. I did leave off IT, didn't I? That's right. Yeah, it's going to be a remote call for sure. I'm just joking.
Yeah, exactly.
So what would this bed governance committee do? They would approve system-wide standards, prioritize bed placement. This is an interesting one that's happening. I mean, it's capital is a resource, right? It's a finite resource. And sometimes some systems, it's the biggest voice in the room, right? The most, whatever it is that gets the dollars. By having a committee that's formed, a multidisciplinary committee, it creates a reduced chance of you losing funds to a CFO in the middle of the year, because they have to disappoint four hospital department leaders and an executive to make a change to that. So they can prioritize bed replacement, monitor those metrics, whatever strategy we have. Hey, we went to this bed model and things have changed. Why? We can follow up with that. Aligning capital with organizational priorities. So patient satisfaction, I mentioned the word throughput. Patient satisfaction is another hospital executive term that if you talk about that with your leaders, they're going to feel like you're more connected to them and they're more likely to give you what you're asking for, in my opinion. So by talking to them about, listen, patients, and what I say is the two places that are most important or that patient spends the most time with are their ceiling tiles and their bed, right? And so that's really going to impact patient satisfaction. They're looking at their ceiling tiles to see if their room's clean, and they're in the bed, obviously, most of the time that they're in there. So that's where your patient is going to feel the investment that you've made in either the infrastructure and the equipment as an organization. Along the same lines of performance metrics, tracking fleet health. So standardization, how do you reduce standardization and reduce complexity? One is to limit bed models. Has anybody been through that? Has anybody went through? Go ahead. So, Noah. Woo!
We integrate something to reduce our cost, reduce how different models we start to see.
Oh, then you left right on. Okay.
It's inefficiencies. Honestly, it's cost. It's time for testing. Oh, we don't have that parking. We don't have that parking. That's 15 to result.
Right.
So there's a lot of efficiency. So consolidating that to 2 to 3 models, and then stepping away from that, need something special for certain
Mm-hmm.
versus having them in-house and have to maintain something to touch 2 times a day.
Right on. Yeah. Exactly. Another opportunity right here is unified service contract. So again, like I was talking about earlier, this is from a multi-system perspective. It's not unusual to come across a hospital system who has the supply chain running a bed contract in hospital A, facilities runs a bed contract in hospital B. Maybe they're the same vendor, maybe they're the same terms, right? You then fall into, there's more accounts receivable, accounts payable on you now. You're running multiple contracts different ways. So it's just not a lot of efficiency in it. So that's a place for you to consider standardizing. Back to what you were saying, accessories, right? If you have bedfall, bedfall in it. If you don't, you want to understand that. You really don't want to work in a hospital where a third of your beds you have to pull out a POSI alarm. You're right. I mean, that's really where the fall risk management, again, this is my experience. My experience is that fall risk management's biggest opportunity is setting fall alarms correctly, right? So having that built into your bed program or into your bed and working with your nursing is going to reduce that as a challenge and reduce the accessories and that you're having to work with on there. Part strategy, like you mentioned, cleaning protocols. I think this is one of the more important ones right here. Part strategy, yeah, that's important. That's going to impact your availability some. Not understanding your cleaning protocols, like we talked about earlier on whether or not EVS is, or whoever is cleaning your mattresses, finding puncture wounds and tears in it, and addressing them. That's one of the biggest things you can, impacts you can have, positive impacts is standardized cleaning protocols. Another thing to keep an eye out is what are they, are they doing it right? You may not be cleaning it, but you're maintaining it, and that's really going to impact you. If they're using the wrong disinfectants, you're losing buttons pretty quickly, right? You're losing monitors pretty quickly. PM standards, it's going to make your PMs faster, your repairs faster by reducing models, how you get to a battery, how you change a battery, right? Really matters. Learning. I was telling someone, the first time is the worst time, right? You're just trying to figure out how to get to that board, and so reducing that's going to help you. Sure.
So what we can learn too is as we standardize to provide you parts. Because once they get your business and you're standardized, it's 10 years for a life cycle or something, right? So it's very important that you get those dedicated parts guaranteed in the beginning. For the life cycle,
for the duration of your, great point. So Lynn's she's not only an HTM expert, she's a supply chain expert. That's a great point on the purchase and why you need to partner with your supply chain department, right? And on this bed with a bed committee to ensure that. Say that one more time, just so it's.
If you can't get the parts, you can't fix that.
Right. Right.
So negotiating when you start to do those capital purchases, a guaranteed parts threshold, right, for boards and different things like that, so that you can make sure that you can keep them.
Right. So you don't want to go into a 5-year bed strategy, right? So not only when you're buying it, then you're going into a 5-year bed strategy. You want to make sure that on year 5, when I buy that one, that I still have at least 10 years of beds parts left on that back end. So that's a great point. Thanks for calling that out. Yes, that is a great time to ask for training, extended warranty, anything else you could get. Yeah, because they're not going to give it to you after you cut them to PO, right? So a comprehensive life cycle approach is important, and I think it really starts with a complete inventory. A lot of people do not know what they have. You'd be surprised. Again, it's really easy to accept when you see that beds are so non-universally maintained, right? That they're not going to have a great inventory. UDIs now, I'm sorry, beds now, I see many of these are coming out with UDI on the footboards, right? So that's a great way to do inventory. We can talk about that later after. I don't have that in this deck, but if you wanted to do inventory using UDI and footboards on beds, we can talk about that later. Useful life modeling, evidence-based determinants on how long a device is, right? Or as a device should be in your system. So standard, your books are going to say 10 years, right? Does anyone throw their beds away after 10 years in here? Zero hands, right? No one does. So what is the useful life of my mattresses? Now here's another place you're going to want to connect with your CNO, right? To gain, to gain trust, to be able to, that we were talking about earlier, is make sure that they understand that you have not just for infection prevention, but for wound care, right? If your OEM suggests a 5-year mattress, that your mattresses are no longer good after 5 years, you need to either go by that or extend it in writing, right? You have to know how long your mattress should be in use, or have some way to test it, or to oversee that. Anything else on that? I've been through that. Anybody else been through wanting to keep beds frames longer than their mattresses? Anybody really worked on that? Yeah, okay. Well, a question on that. Is anyone who is calling out expired mattresses? Is anybody calling out expired mattresses? Right. So again, to that point, good point. Replacement hit, everyone, ideas, everyone has a plan until they get hit in the face. What Mike Tyson says, that's kind of your budget too, right? Everyone has a plan, but by understanding a multi-year plan and having even a capital pool for these beds, they're so important, right? If you accept that your patients are going to be spending the most time with them, separating beds as its own capital pool may be a consideration as well. And then you're going after a general or other pools. Failure rate analysis will allow you to create an AEM, so an alternate equipment management program, or just the life cycle. How often do we need to? When do we see this spike? By following. That's not the AEM. Sorry, I misspoke. A failure analysis will allow you to look at both an AEM, but I'm really talking about life cycle management when you need to repair. So if you say I'm only getting an average of 1.4 work orders per year on beds younger than 12 years, but I'm at 8, I'm at 3.8 work orders 12. This is our replacement point, right? Data hopefully is available for you through your CMMS that way, and then analysis through Copilot or whatever your enterprise AI is. I'm gonna keep going just a little bit. Time check. Oh man. It's the longest 15 minutes of my life, I gotta say. Back out. I mentioned number 4. I mentioned replacement waves. You're going to cut an XX million dollar check, right? You want to avoid that. Those heavy waves if you standardize it. So by doing that, let me look real quick. Real quick before I go to that next one. For your mattresses?
For mattresses.
All right, thank you. Yeah. Right. Good point. So having the OEM, I'm repeating what you're saying so it catches the mic. Having your vendor, whoever your mattress supplier is, I would not ask. For me, I wouldn't feel great going back to earlier, making decisions based on if my family member was in the bed. I would ask my vendor to do it annually, right? Or to have an annual plan. 3 years is a long time or multiple years is a long time. Go ahead.
So I was curious about like the infrastructure of these beds, right? mentioned that the goal is to keep them basically the same over, so you don't have to retrain your staff and everyone to learn how to use it. But when they're building these new features, the companies that make these beds, are they like keeping that in mind? Like, do they build the features, the new features on top of the old infrastructure of the bed? Or
Sometimes, yeah. Sometimes not. I mean, that's the whole point of, taking, I think, taking your innovation leaps right at a time. So generally, you should, like we're talking about, you should commit to a bid for, platform for what, 5 years probably before you consider, we need more innovation, unless something just really happens. So yeah, and you're weighing that. Do I introduce another model? Is this new innovation worth another model where they already have beds that have cell phone chargers built into them, right? You know what I'm saying? I don't know where we're going, but
And to keep that in mind, so usually clinical education is a big deal, right? So there's this new training on the features, so they'll try to make them very settlement, like just tweak. It'll have new functionality, but they'll try to keep it like that so that the nurses are not having to be retrained.
like keep everything in the same place.
Exactly, kind of like same dish. Yeah.
I actually do want to hit these points real quick. Service model definition. So you will have a strategic choice between in-house, hybrid, or even ownership. So to touch on that is, I have worked with and implemented programs that were rental only, right? So I have a fluctuating census. We don't own anything. If it breaks, you come pick it up, and you have to perform PMs throughout the year. The total cost of ownership was very close. Once you say, how many bed techs do I have? It wasn't cheaper, right? You know what I'm saying? So again, you're looking at where am I at on my capital purchase. So you have to include capital in that. So I'm in a position right now where I have to write a $20 million check, or I have to capitalize rentals, on this, operationalize rentals for my beds under this program, right? That is a strategy. I'm not saying it's the best strategy, but there are definitely times where I can't cut a $20 million check. I'm going into rental mode. And then those same programs will give you credit towards that capital where you can buy them later in the agreement. Anything to add to that you've seen? Or you can also outsource it to a vendor. We're going to talk about why you may do that here in a second. That's an option to you. And this was number 6, was what you just brought up, is future proofing your features, or, really looking, and it's really kind of what Lynn and you were talking about, either your accessories, like, am I going to have 10 years left after my last buy on this 5-year strategy? Well, the question is if you select some nurse call capability, et cetera, is that nurse call going to be supported for another 5 years? Like, make sure you're future proofing all the things you're going to work, all your things you're going to work with. This is a great point when you're wanting to connect to multidisciplinary leaders fast. If you're wanting to connect to your supply chain group, or someone that you're going to ask for a change, to visualizing that data, right? So right here, bed age distribution, what is my target? I know they're both blue, but what is my target, and what does our current fleet look like, and how do we change that? Also, if you're in a large organization, am I getting rid of, does hospital A, is the average bed fleet, what is the average age of the bed fleet? Is it, for example, this is kind of the same thing, beds purchased by year. I have a big, huge spike. So I either have to plan on this to have a similar year where I'm going to have to do that again, or I'm going to have to relieve some pressure in my future strategy. So by having this life cycle map where you can visually communicate the current age of your fleet, will help you financially plan, reduce surge needs. Any thoughts on that? Thing to add? So step by step, if you want to build this plan, governance is going to be very important. In my experience, what the biomed said doesn't always drive what's going to happen. So you can lead by you can lead and influence by title, right? Or by what I said, by governance. This is one of the best ways, right? It's less pressure on you on the outcome because it's through governance. It's multidisciplinary, more than you just made that decision. But you might have to drive it, right? Conduct an inventory-wide system. Conduct a system-wide inventory. Probably physical audit if you're really serious about it and you don't trust it. Standardize the nomenclature. What we see is striker with a K, striker with a C. Not that bad, but it's pretty bad, right? We see manufacturing models that are not consistent. So standardize your data, perform a condition assessment. All of that will, depending on the size of the hospital system, could take 12 to 18 months to set up. If you started now, it could take 12 months to get your finance leaders, your nursing leaders, and all of the people that we just talked about, facilities, have this completed, sit in front of them, and really begin on a plan. It's not quick. We did just talk about this. Fully in-house models. What are your service models? Fully in-house, a hybrid approach, or vendor service. I've done all three of them. Well, I think we are going to talk about advantages to both. Let me see. I don't know. We'll talk about it here. I don't know if we address it later or not, but fully in-house and the disadvantages to both. We might see this in another slide. We'll see. But pitfalls of an in-house biomed program. Anybody?
My first job was that's house list, so we taken over from the vendor and then built the building from the ground up.
Okay.
Problems we had really parts acquisition, organization. There's kind of chaos prior to good vendors, and so when Jago quite trouble. So
that's pitfall of vendor management. But what's the pitfall of in-house? What are the challenges when you're, go ahead.
You lose one critical staff member down, you don't have a contract in place. And if you have a large fleet, it takes a lot of time.
Right.
Even if the EM isn't a long procedure, it takes a lot.
So resiliency, possibly, staffing resiliency. One of the things I was looking for was biomed might not be a 24-hour department, right? And on call, right? So what are some ways to defend that? So if you're not a 24-hour department and you have bed maintenance, bed go down, what are you guys doing? EVS, perfect, yeah. So there's an answer for it. You have and that's fine as long as you have an answer for it. What about bed extenders, nurse call, anything like that? Right. Okay. And what about you?
Same.
Same.
Yep, nurse call, home by IT, and then extenders after hours, because they're 24 hours, they would assist even with like
Okay. How do you put that and roll that into policy? How do you make sure that happens and continues to happen? And just, if you don't mind. You do it in a work order system. Excellent. Okay. So it's timed, right? Okay.
Document when the clock starts, service desk knows the hours of biomed, they know when to make it that
Right on. Anyone have anything else different? What happens if a bed, you have extra beds waiting?
Okay. So we do have an on-call, but the nurses have access to the storage rack.
Okay.
They can access what we have in storage.
Okay, and if not, the work order's waiting for you guys in the morning. Okay. That's what interesting thing about beds too, and really going back to that bed rental, there's bed rental options, kind of what you were just saying. Has anyone in their career ever seen an accrediting agency show up And then magically you go down to the basement, and there's no more beds down there. They got on an 18-wheeler somewhere, right? You know what I'm saying? So yeah, they're driving around so they're around the bypass circling, right? But that can be a challenge too. So bed storage, and we won't touch on that too long, but if you are paying for bed storage, beds are, used beds are not that valuable, right? You know what I'm saying? Unless you just don't have it. So consider a MOA, a memorandum of understanding with a rental company on beds, and get rid of the ones that you're just paying probably $35 a square foot storage, right? For them just to be taking up room for you. Hybrid approach. Has anyone seen a hybrid approach? Because I think you were talking, you were mentioning, resiliency and labor staff. Have you seen a hybrid approach, or is that anything you can address? Or
I haven't seen it in the place I'm in, or the VA, so.
okay.
We have an option for hybrid approach, but it would be for beds only, it'd be for all service.
All service. Okay.
We had one of the losses. Majority was LL, except they took on the roles of LL. They were very little bits. However, we had a 30% of the starter.
Okay, right. So hybrid, that's an example. Hybrid. I've run the same thing, the rental program through hospitals that I could not staff appropriately, or.
Try the hybrid approach, a little bit, but being in Alaska, we were having issues with staffing themselves. We stopped.
Okay.
We just took it in-house and trained as many of our techs as we could, because the vendor may or may not have the staff.
Right.
They change the contract. So that's common.
That's true. Yeah, that's a good point. And
I will say, as I read the hybrid approach, we have a full service vendor, but we currently do more of a hybrid approach. Just because the full service vendor can't get in time. So even though it's not designed to be a hybrid approach, it's all into a hybrid approach. To where, right, hey, we have this tablet for you, if you need to program the mattress.
right,
So
yeah.
it's like, oh, just do it. So.
Are you with an OEM? Okay.
So it would be first call when it's a facility, they did own the beds, and then they had a PM agreement for a third party to come in PM the fleet. So that was there.
Okay, I like that too. So a PM approach, they would do correctives, and then
In-house correctives, and then PM the whole fleet.
that's the way I like to do IV pumps. I'm just kidding. Yeah. Yes. All right. That's a great approach too. Thank you. If you think of something that's innovative, definitely jump out with it. We still have time. We're only halfway through. We may not make it anyway. Integration with patient flow. So they don't just support patients, they drive, again, that word that I talked about, throughput. Direct throughput benefits, reduced onboarding, ED onboarding times. If you have someone waiting for a bed and it's actually waiting for a broken bed, obviously that's bad. They get into their bed, and this isn't just beds. This is EVS. This is, so many functions when you think about throughput. This is an engine, and every valve has to work, every spring has to work for healthcare to work, to work flawlessly. Beds are definitely part of it. What was I gonna say? Oh, I thought, no, we got time, trust me.
We don't asset tag wheelchairs, they're kind of like an anomaly, but they also don't get paid by EVS, and they don't, in general, like they're kind of there for the volunteers, and volunteers will do stuff with them. So I don't know if you have input on that as to like what should happen.
Yeah. That's a good question. I generally like to pair that same work together, right? Now, not infection, again, that goes back to a RACI. When you talk about a wheelchair and who cleans them, that would be found on a RACI, and I would think it would be EVS, because again, I believe that this is a skill set. Again, I used to lead EVS. We discussed earlier. I believe the EVS is a skill set. It's not you don't just plug somebody off the street. They learn how to do what they do, right? So why would I want to teach a volunteer the proper way. You know, if that's the only thing that they're going to disinfect, why would I teach them how to do that when I have a specialist? And there's nothing more important, not much more important than disinfection and, you know, infection prevention in a hospital.
And also for repair, like if they're not inventory for us, not really inventory for facilities, or at least that's been my experience.
Right.
They're just kind of there and in use and no one really.
It's a good point. That's something I never got. There's places I've been to I never got around to on that. But I agree. I think if someone says, "Hey, who's going to do these?" My question is, who does the beds? Is it biomed or is it facilities? If it's biomed, they should do the wheelchairs. If it's facilities, I think that you should pair them to it. They're close enough together. And then, you know, same thing. A bed tech who works on beds, dealing with fluid invasion or something like that as they receive a repair is going to be, you know, the bed tech will understand disinfection, should too, so the person repairing the wheelchairs.
So I know the meeting with our VA and VMS and system, there's a patient transport chair, which is small wheel and wheelchairs. And Biomed does not deal with wheelchairs at all because those are pushed and can be propelled by patients, whereas transport chairs have to be transported with clinicians. So they're hospital equipment. That's where our line is. We tag our patient transport chairs. And we've standardized to the new Striker that are easier, they're more expensive. But yeah, well, no, the small, yeah, smaller wheel, but patients can't push them themselves. You have to be driven in them.
Yes, I've seen
So,
those.
and those are easier to clean. So we also, and in the VA, especially in the 5, a lot of our biomedical engineers are all basically do a lot of the equipment cleaning functions. So we can't have too much say, but we have a lot of the driving factor to differentiate in their equipment. So we include, oh, is this easily cleanable by EPS so it will get clean? Is this, who's going to be responsible for it? And are they speaking up and having a voice? Because we know as biomed, a lot of times it will fall to biomed if it isn't thought of in the beginning. So
Right.
with this intentionally.
Exactly.
What I was gonna say earlier, just briefly, that's priority, is probably the number one to better money. Somebody, certain nurses like, oh, this thing's down. Like, okay, do you understand? We have an actual, yes, I have another one. I'm working on the middle here, right? I can't take over. But in a lot of cases, the staff is like, they don't care about that. It's like, oh, it's broken, it's on the back burner, until it's a major problem. I think that's the hard part, is like standardizing how. Like, it's not hard enough to train them. Swap out. I'm not going to go in there and work on a bed when there's a patient that's pretty critical. I'm not going to touch that bed, but they have expectations of us fixing it right away. So how, like, I'm trying to stay up there with 2 other guys that I work with, just localizing to them and saying, we will take care of it. It doesn't switch that portion, but we can't take care of it with the patient one. So that becomes a problem. I've seen that multiple.
What do you, what's their response when?
Usually it's not good. Well, I can't believe we'll work on it now. It's a simple fix. It's not simple. As much as I'd love to say it's simple, it's not. And there has to be a soft pushback.
Right.
Friends with them all the time. You can't really tell them they're wrong.
Mm-hmm.
It's just gently guide them into the correct answer.
I do. I'm just kidding. I'm married to one. Yeah. There is definitely a balance to it. Anybody else have anything to say to that? I think, go ahead.
I find analogies to their expertise work the best. Like you, like, hey, doc, I understand, but that's like somebody coming into the ER with their head split open versus a cold. I mean, I got to do one or the other. And then you'll get, well, I don't care about that patient. Well, I care about all of them. So yeah, like you kind of flip it to where you.
Yeah.
But some won't work. Some, I don't care. And some will be, oh, I'm sorry. You know. Yeah. Well, that's first.
That's unusual. No, I'm
You're
kidding.
the empathetic representation.
Yeah, I don't think that's really, I mean, I do think again, understanding what's important to your customer. It's all, this is a that's a different class, and it's about communication, right? Yeah. Right. Yeah, yeah, I agree. Yeah, you know, having, yeah, in policy, most, you know, I could even have an imagine in policy, you know, these are the times where we work on equipment with patients in the room, right? And it would be unusual, but there is still a time where it's appropriate. Yeah, but I've had times where you know, a facilities general maintenance person would not walk into a patient room to replace a clock, right? Well, you took the wrong job. You're in healthcare, right? You know what I'm saying? So, I mean, that's one of so there is balance. And I think, you know, calling out in policy, you know, where you deviate from practice is where, you know, will help you in that. Yeah, yeah. Sure. Yeah.
During the day, while patients are up there.
Right, right. There's times what I think, again, everything you do is in the best interest of the patient. What you just said, you're talking about, you know, connecting with them. If you connect with the patient, you will connect with them, because they're not complaining out of their lack of empathy for the patient. It's because they're being a patient advocate, right? So that connection is going to help you. So operational improvements, if you really work on focusing on hospital bed efficiency, you'll have increased patient satisfaction. Your beds are maintained. Somebody knows your bed. Somebody owns your beds, and there's a RACI that describes that ownership, right? Reduce cost over time. We didn't really talk about improved bed placement or accuracy, but that really goes back to what inventory do I have? What resources do I have? Oh, this isn't in this deck. Some hospitals, and Lynn mentioned it, talking about bed board. Some hospitals will have a bed board that are, even my favorite right now are wireless bed boards. So you push the bed up right now. You don't plug, even the nurse call is not plugged into the wall. So that's the future. You're getting less cords ripped out of the wall, out of your bed, etc. So that's coming as well. So survey readiness and alignment, that's another place. If no one knows who owns the bed, how do you know that your maintenance is being done? How can you pass a survey? So that's definitely a place that you need to consider. Infection prevention and documentation accuracy. That's what these are all things that the Joint Commission, DNV, CMS are going to be looking for. They require you to demonstrate evidence that you're keeping the equipment up properly, that you've performed PMs and maintenance, and that you have performed by manufacturer's guidelines or have an AEM. I want to touch on this now in case I don't get to it or in case it's not in here. An AEM is an alternate equipment management program or maintenance program. Does anyone have AEM on beds here? Talk to me about it. Do you have a IoT solution? Okay, so if you don't have a wireless RTLS system, you do have an IoT solution, and your IT has mapped out their wireless access points. Get with Lynn Holland, and she'll tell you she'll tell you about how to. Yeah. We call it. I call it. That's what I call it too. The poor man's RTLS is through an IoT system. They've done it, and there's other systems that have done it. If your beds touch the network, that's a way for you to yeah. The hospitals I've seen implement that, the poor man RTLS, you see an increase in both bed and pump completion percentages.
I was just gonna add to your procedure one. So we do that. We open our work orders at the beginning of the year. Strikers, ICU PM procedure set, their med surg procedure set, and we turned it into fillable fields. So as they're doing that, all the documentation right. they're laid out very well. They're pretty good procedures.
All right, so this is a system-wide bed rental life cycle program, and this discusses the advantages of or how a rental program can support it. So we've talked about a lot of these topics. So eliminating storage burden, rapid off-site swap outs, which you have to be. You brought up a concern where sometimes vendors don't provide what that they say they're going to. So you do have to be careful of that. Lowered HTM workload. So a consideration on either making a bed program, making your own bed program where you have bed techs, where you could be creating a pipeline of future biomeds, right? Having a code of bed tech. That's an opportunity. So but if I guess I'm kind of squirreling on you right now, but lowered HTM workload, whether you're renting them, whether you do them through a vendor, or whether you have your own job code or description, that's something to consider. You won't have to, if you're having a capital problem, means not enough money is a capital problem for beds. Rentals will help you on the life cycle. And that can happen. Yes. Yeah. I feel like the hospital systems that probably benefit the most from rentals are going to be ones that have a census fluctuation, heavy census fluctuation. I'm not sure about you, kind of special case. Specialty beds. Yes. Yeah. Specialty beds are you're going to likely do rentals in specialty beds. If you have exorbitant amount of rentals, you can. I did a consultation with Systemwide. One was pretty large. Did find specialty beds for capitalization, but you have to be pretty big for it to work, right? For you to want to do that.